Antimicrobial does not mean antibiotic. While those two words do sound similar, they describe two very different things. This distinction becomes especially important when we're talking about diabetic foot ulcers, chronic wounds, bioburden, infection, topical wound products, and antimicrobial stewardship. So today in Diabetic Foot Files, we're going to break down that word antimicrobial, what it actually means, and what does antibiotic mean. Because sometimes patients will come in, sometimes, and they'll be like, "Oh, the doctor gave me antibiotics," and it wasn't antibiotic; it was just like a dressing, and things like that. So, why choosing an antimicrobial dressing does not automatically mean that you're treating an infection with antibiotics. It doesn't mean that. Okay. So, what does antimicrobial mean? So, let's start with the broadest term because the antimicrobial term is the actual broad one. So, antimicrobial essentially means something that acts against microorganisms. So, that can include organisms like bacteria, fungi, yeast, some viruses, and some protozoa. So, antimicrobial is an umbrella term, and an antimicrobial agent may inhibit microorganisms, can kill microorganisms, or interfere with their ability to survive or reproduce. But that does not tell you exactly how the agent works. And it certainly doesn't automatically mean that it's an antibiotic. Does not mean that. So, what is an antibiotic? An antibiotic is a substance that acts against bacteria. So, in clinical medicine, when we talk about antibiotics, we're generally talking about drugs used to treat bacterial infections. Examples are like amoxicillin, cephalexin, clindamycin, doxycycline, ciprofloxacin, metronidazole, things like that. And these medications can be administered systemically, as antibiotics can be used topically in particular circumstances. But the key point is antibiotics are working against bacteria, only bacteria, because it's an antibiotic. Remember how there are doctors that say they don't like when patients ask for antibiotics when they have a virus? Yeah, because it's an antibiotic. It's for the bacteria, not for a virus. It's not an antiviral. Okay? So, but yes, you can have a virus and it can cause a bacterial infection, but that has been a thing. Like patients will come in with, and I'm just talking about like just the common flu and things like that. They come in with a virus and they ask for antibiotics for a virus. But that those it doesn't work, okay? So antibiotics are directed against bacteria, only bacteria, to my knowledge, okay? Only bacteria. But antimicrobial is a much larger category. That's why I like antimicrobials. So think of, every antibiotic has antimicrobial activity, but not every antimicrobial is an antibiotic. Let me just say that again because I want people to understand it. Every antibiotic has antimicrobial activity, but not every antimicrobial is an antibiotic. Because remember, antimicrobial is the bigger umbrella where you could do yeast, protozoas, just microorganisms, living things, okay? Then we have antiseptics, which I love, okay? This is where we get a little bit more interested. So an antiseptic is an antimicrobial substance intended for use on living tissue. That's the difference. So examples would be providone iodine, chlorhexidine, hypochlorous acid preparations, and some alcohol-based preparations. So an antiseptic is not synonymous with an antibiotic. So therefore, you have antimicrobial, so that's the umbrella, and then underneath that umbrella, you can have an antibiotic and an antiseptic, okay? And you can have other antimicrobial approaches as well. But just the key factor is that the terminology is completely different. There are different applications in different categories. So why does this matter in a diabetic foot ulcer? Because a diabetic foot ulcer is not automatically infected simply because a microorganism is present, this is one of the important factors and concepts in wound care. A chronic wound, they're usually polymicrobial, right? A chronic wound is exposed to environment, and microorganisms can be found in wounds, but microbial presence does not equal infection. Okay, so you have to distinguish between that concept. So there's contamination, there's colonization, and then there's infection. So contamination is microorganisms are present, but they are not necessarily multiplying or affecting the wound. Colonization, microorganisms are present and may be multiplying, but the patient does not necessarily have a clinical infection. An infection is the microorganisms are interacting with the host in a way that produces tissue damage and a clinically meaningful response. Okay, so it's you can see those three situations are quite different. So why would you use an antimicrobial dressing? So this is where the distinction becomes clinically useful. So a clinician might choose an antimicrobial wound product for a variety of reasons related to microbial burden or just wound management. But using an antimicrobial dressing does not mean that the wound has an infection and I'm giving the patient antibiotics. Does not mean that. Those are two different decisions, okay? So, for example, a topical antimicrobial strategy may be considered as a part of managing a wound with certain concerns about microbial burden, okay? Particularly when the clinician believes that the product characteristics would be appropriate for that wound, okay? But it does not replace the clinical assessment for infection. So, one of the biggest misconceptions is if I use an antimicrobial dressing, I'm treating an infection, and that's not necessarily true. You have to ask, what am I trying to accomplish? So, are you managing the micro burden, the preventing the contamination of the dressing or the wound environment? Are you managing the wound with suspected local microbial issues? Are you treating a clinically infected wound? Are you treating an established systemic infection? These are different scenarios that require different interventions, okay? So you have to choose wisely. You can't just say, okay, this is antimicrobial dressing if the patient has signs of clinical infection, right? They have signs of clinical infections, they need a deeper assessment and to see if they do need antibiotics. But antibiotics stewardship does play a role in this as well, okay? So keep all this stuff in mind. So a topical antimicrobial does not equal systemic antibiotic, okay? So imagine a patient with a diabetic foot ulcer. You decide that a topical antimicrobial product is appropriate for the wound. That does not automatically mean that the patient needs oral antibiotics or IV antibiotics. But if the patient has a clinically diagnosed diabetic foot infection, putting an antimicrobial dressing on the wound does not constitute adequate enough treatment for the infection, okay? The patient most likely would need antibiotics, right? You have to culture, figure it out. I would consult infectious disease, but you cannot substitute a dressing for appropriate infection management. So, and quick side note, yet again, quick side note, do not self-treat, okay? And do not take expired antibiotics or your neighbors or friends leftover antibiotics. Don't do that. Simple as that. Just go to the doctor, okay? Because it is a thing. Do not do that. Big do not, okay? Big do not, because it also would create resistance. You might be allergic to it. You don't know how old it is. You don't even know what, you know, it's a mess because most people, they're taking other pills, but I've had so many patients come in and say I say, "Oh, have you what what have you been using?" And I love it that you're telling me the truth, be fully honest. They always say, "Don't ever lie to your doctor, don't lie to your lawyer," right? And patients will tell me that, "Oh, I have my sister or brother or neighbor or my friend gave me their leftover antibiotics and I was using it for a while and the symptoms didn't improve and that's why I came to the doctor." So don't ever do that. Don't ever use somebody else's antibiotics or expired antibiotics if there's a wound. The biggest thing is, right? Yes, check your feet absolutely every day. But the biggest thing is the moment there is any breach of in the skin, right? Any break of the barrier of the skin and you're a diabetic, go to the doctor immediately. Okay. It's much easier to treat a very, very small wound that has uncomplicated problems than coming in when there's a big infection. So don't ever self treat. I promise you, you'll save so much more time and probably most likely your limb. If there's any break in your skin, it's not you doing too much, being overly cautious. I don't think anything's wrong with that, okay? Because we already know how quickly diabetes or diabetic foot ulcer or diabetic foot infection can go left real quickly. So just keep that in mind. Okay, now let's go back to antibiotic stewardship. So one of the biggest problems in medicine is unnecessary antibiotic exposure. That's why I was talking about, the patients coming before coming to the doctor, they will use other people's antibiotics or their old expiring antibiotics. Like, oh, they'll be like, oh, I had to have leftover antibiotics from my last infection a year ago or something like that, right? But antibiotics can cause adverse drug reactions, gastrointestinal complications, drug interactions, selection for resistant organisms. So you're playing a role in that if you're doing that, changes in your microbiome, and you can even get C. diff, okay? Infection. So when we give antibiotics, we should have a reason to give the antibiotics, right? A diabetic foot ulcer that is simply open does not automatically give an indication for systemic antibiotics, okay? A wound can be chronic, a wound can have slots, a wound can have odor, a wound can have colonization, a wound can have bacteria detected by a laboratory technique, but none of those facts alone means start antibiotics. Clinical diagnosis matters, okay? So, like I said, and then antimicrobial does not automatically mean better either. So we sometimes fall into this mindset. If it's antimicrobial activity, that means it's better for wound healing, right? And that's not necessarily true. The wound is its own biological environment. It has a very high metabolic demand, and we're trying to support a bunch of processes going on all at once to try to close this wound, such as keratinocyte migration, fibroblast activity, extracellular matrix formation, angiogenesis, granulation tissue development, reepithelialization, appropriate inflammation, and remodeling. So when we're selecting a topical product, we're simply not just asking, does this kill bacteria, right? We're asking, is this appropriate for the wound at this stage, right? For at what stage this wound is at for this patient for under this clinical objective observation, okay? So that's a better question to ask, okay? So, antimicrobial activity can work in different ways. Different antimicrobial technologies have completely different mechanisms. Some disrupt microbial membranes, some interfere with microbial metabolism, some release antimicrobial ions, some generate reactive oxygen species, some bind to the actual microorganisms, some physically remove microorganisms from the wound environment, some create conditions that are unfavorable for microbial survival. So when a company says addressing its antimicrobial, we want clinicians to ask, what's the active mechanism? Not just, is it antimicrobial? So silver is a great example, right? Silver containing products, I'm not gonna lie, I love me some silver cell, okay? But silver can exert antimicrobial effects through several mechanisms involving silver ions and the interactions with microbial cellular structures and protein. But that does not make silver an antibiotic. It's not, okay? It's an antimicrobial technology. So the clinical question isn't simply, does the silver kill bacteria? The question is, when does this particular silver containing product make sense for this particular wound? So, that's a more sophisticated approach when you think about it. So, silver containing materials, they release silver ions, and the silver ions interact with the microbial cells. And those silver ions can damage the bacterial cell membrane. So the silver ions interact with the protein and the membrane components. This increases the membrane permeability and disrupts the cellular integrity, and the organism essentially loses control of what enters and leaves the cell. Another thing that silver does is it has strong affinity for sulfur containing groups, particularly thiol groups in proteins. So this can inactivate enzymes that bacteria needs for metabolism and survival. Another thing is silver can disrupt enzymes involved in electron transport machinery, and the organism becomes less capable of generating energy so that it won't be able to survive as well. And then another thing silver does is it can interfere with the nucleic acid process and replication, so pretty much the DNA, and this makes it harder for the microorganisms to reproduce. And then it also increases oxidative stress, so it contributes to the production of reactive oxygen species and oxidative damage within microbial cells. So, this isn't just platonic bacteria, particularly it's interesting that silver can have activity against organisms in biofilm associated communities. Although silver should not, you know, be like a magic biofilm eradicator, but they have other mechanisms too, like other antimicrobial dressings to help with biofilm, but I mean, it doesn't replace debridement. Nothing replaces debridement, okay? Nothing replaces removing the devitalized necrotic tissue and soft tissue or even bone if bone is involved, okay? Silver does not replace source control, does not replace offloading, does not replace vascular assessment, does not replace if there's appropriate antibiotics needed per antibiotic stewardship. I'm just saying that to protect myself. So, another thing, iodine. I love iodine, okay? Iodine is not an antibiotic. Iodine is an antimicrobial as well as an antiseptic. So always keep that in mind. Hypochlorous acid is interesting because it's part of our body's innate immune chemistry. But once again, it has antimicrobial purposes. It's not an antibiotic. Now, honey. I actually love honey because, current medical grade honey products have antimicrobial properties, but honey isn't an antibiotic in a pharmacological sense, right? But I've had patients like been saved by honey, like medical grade honey. So I can't I can't talk ill of it ever again, to be honest, after experiencing that and it helping me save that patient's life. Another thing is polyhexamethylene biguanide, PHMB. So is another antimicrobial agent used in some wound care products. This is an antibiotic. Like I said, it works through interactions with microbial membranes and other cellular components. And again, the important question is not merely whether it is antimicrobial, but do we need this? Do we understand what does it do for the wound? How does it work for the wound? And is it appropriate for the wound? And then we covered a little bit about biofilm, but biofilm, you know, people have a misconception that biofilm means infection, therefore antibiotics. Not necessarily. Biofilm management is a much broader problem in wound care. Like I said, debridement plays a huge role to help with biofilm because biofilms are structural mic- microbial communities that help them pretty much survive. It makes this protective extracellular matrix, right? But biofilm management, like taking away the biofilm, can involve debridement, mechanical disruption, wound cleansing, appropriate topical strategies, even moisture management, addressing the offloading, addressing ischemia, addressing necrotic tissue, and addressing underlying cause of the actual wound. So there is, if there's a clinically diagnosed infection, appropriate antimicrobial therapy, including most likely systemic antibiotics per, let's say, infectious disease recommendation may be necessary, but biofilm management and antibiotic treatment are not interchangeable concepts. So hopefully people can understand that. So, as we all know, the diabetic foot ulcer is its own ecosystem. It's an ecosystem that's involving the host tissue, the immune response, the blood supply, the oxygen availability, has neuropathy most of the time, pressure, shear forces, necrotic tissue, extracellular matrix, microorganisms, biofilm, inflammation, and metabolic demand and abnormalities. Okay. So, when it comes to intervention, it has to fit the biology of the diabetic ulcer. So you cannot treat the microbial component while ignoring the ischemia. Remember, we love vascular. You cannot treat the infection while ignoring uncontrolled pressure. You cannot repeatedly change dressing while ignoring the underlying cause of the ulcer. You cannot assume that every microorganism detected in a wound needs an antibiotic, okay? So, I want people to remember antimicrobial means activity, antibiotic describes a specific class of antibacterial therapy, okay? So there's a distinction, okay? Not every bacterium needs an antibiotic, okay? So keep that in mind. So, when we're evaluating an antimicrobial product, we need to ask like what is the active agent? What mechanism of action is it working on? What organisms does it affect? Is there evidence in the type of wound that I'm treating? What is the intended clinical indications? What are the contraindications? How long should this dressing be used? What happens to the surrounding tissue when this dressing is used? Does the patient actually have, and also does the patient actually have an infection? And, always keep in mind antibiotic stewardship, okay? So, anti, we already said it. Use antibiotics when it's clinically indicated and use them appropriately. I already talked about the aspect of that, okay? So, the final takeaway is next time you hear somebody say this is antimicrobial, so it's basically an antibiotic, that's a no no, okay? That's a no no statement. Don't ever say that, okay? So, those are not interchangeable. Antimicrobial is against microorganisms, antibiotic is against bacteria. So, antimicrobial is the umbrella, antibiotic is one part of the category or one person underneath the umbrella, one person underneath the umbrella. There's multiple people that could be underneath that umbrella, okay? Antiseptic is another category that be underneath the umbrella, okay? So, in diabetic foot care, understanding the distinction can help us make more rational decisions about bioburdens that affect our diabetic patients and their foot ulcers. So, infection, topical therapy, and antibiotic stewardship plays a huge role. Okay. The goal isn't like, does this kill bacteria? The goal is to heal the patient, right? Save the limb. So, the art and science is knowing which one, why, when, and how long. So, this is Diabetic Foot Files. I'm Dr. G, and take care of your feet because they take care of you.